Good evening, everybody, and welcome to this evening's Facebook Live. My name is Alec. I'm the Managing Director of Wound Care People and Wound Care Today. This evening's session is tackling the chronic wound and the role of debridement. And our wonderful speakers this evening are Duncan Stang, who's an advanced specialist podiatrist and diabetes foot coordinator for the whole of Scotland at NHS Lanarkshire, and Deborah Wilson, lecturer in podiatry at Glasgow Caledonian University and NHS Lanarkshire. Both, how are you? Good evening. Let's do this one at a time because we're just practicing how the whole handover works. Duncan, let's start with you. How are you?
I'm very well, thank you, and thank you for asking me along, Alex.
My pleasure. Debbie, how are you?
Hi, Alec. Yeah, I'm very well. Thank you very much. And once again, thank you very much for inviting us to be here.
No problem at all. So my first comment is just to thank Eleanor, who are the sponsors of this evening and who have put together the content for tonight. I'd like to thank the whole team there. So thank you very much. We have a very close relationship with them. For those of you watching now, just remember certificates will be available at the end of the presentation. We'll put some links up as always. Do ask as many questions as you possibly can, because after the presentation, I'll be back for a live Q&A with Debbie and Duncan. And do bear with us if there are any technical issues. As you can see, for a while now, we've been presenting from our home, so just bear with us. I think it's fair enough for me to mention at this stage that this is the first fully Celtic Facebook Live that we've had, where we've got Duncan and Debbie up in Scotland, myself down in South Wales. So hurrah for the Celts. So are you with me, Duncan and Debbie?
Yay.
You weren't expecting me to say that. I know that I just threw that in there. So I do apologize if I've thrown you. Okay, so that's it. So I'm going to hand over to you now. What's going to happen? Duncan and Debbie are going to do a presentation. I'll be back after that with the Q&A. Ask as many questions as you possibly can. Remember, make as many comments as you can in the comments section. I'm now going to hand over to Duncan. Duncan, Debbie, good luck. I'll speak to you on the other side.
Thank you.
Thank you very much, Alex, and thank you very much to Eleanor for asking me and Debbie to give this presentation on a subject that is close to both of our hearts, which is tackling the chronic wound and the role of debridement. So, an overview of my presentation. What I'm going to do is I will briefly cover the overall principles of diabetic foot ulcer treatment. I'll provide a definition of debridement. I'll describe the different types of debridement, and I'll also then go on to explore where, when, and by whom debridement should be carried out. And then I will cover the competence to enable safe and effective debridement to be carried out. And I shall just move my slide on. That's fine. So let's just quickly cover the different elements that we all know we need to address when we are treating the diabetic foot. And I always look upon this as pulling pieces of a jigsaw together, because there are various elements that need to be addressed. And to quickly cover these are offloading. We know we have to offload any wound that we are treating, and sometimes this can be a difficult aspect of care. We have to control infection, because infection is one of the main elements that leads to worse outcomes and poor healing. And we have to obviously debride these wounds, and that can help control infection, obviously. We have to concentrate on other wound management elements too, and that is controlling exudate levels, protecting the peri-wound skin, etc. And especially in the individuals which Debbie and I specialize in, individuals with diabetes, we have to consider revascularization of a lot of these individuals. So we have to look at all these different elements of care. And if we have one of these elements of care that are not in place, we are going to impact on wound healing. And a very good friend of mine and colleague from America, Professor David Armstrong, quoted saying that it's quite often not what you put on a diabetic foot ulcer that heals it, but it's actually what you take off it. And when we're talking about debridement, that is very pertinent, a very pertinent statement. So if we look at a definition of debridement, and this is a simple one from Wikipedia, but one that I like, the medical removal of dead, damaged, or infected tissue to improve the healing potential of the remaining healthy tissue. And I think that is a very succinct definition. There's also another very good definition, which comes from NICE. It simply states, debridement is an accepted principle of good wound care, especially when the debris is acting as a focus for infection. So that is two slightly different definitions, but I think they capture the essence of debridement very well. So let's talk about the different types of debridement, and this was based here on, this chart was based on work by Gray et al. So if we look at the first method of debridement, that is autolytic debridement, and that is what the body uses its own enzymes and moisture to rehydrate and often liquefy hard eschar. So that is the body's own mechanism of carrying out debridement. The advantages of this, it can be used for pre-debridement when there is only a small amount of non-viable tissue. It is also suitable for wounds where other forms of debridement are not appropriate, and can be used as maintenance debridement. The disadvantage is it is slow and it increases the potential for infection and maceration, but this can be done by both and monitored by both the generalist and the specialist. If we move on to biosurgical, this is larvae, and it removes necrotic and devitalized tissue from the wound. It is highly selective and rapid, but the costs are quite a bit higher for this. But treatment is in one place. It's not suitable for all wounds, and some individuals that I've treated in the past are a wee bit reticent to have larvae applied to their wounds. This can be applied by a generalist or a specialist, but if it is a generalist, they need some specialist training to apply these. Hydrosurgical is the removal of dead tissue using a high-energy saline beam as a cutting implement. Both Debbie and I have used that in the clinic. It is a short treatment time is one of the advantages, and it's capable of removing most, if not all, devitalized tissue from the wound bed. The disadvantages is it does require specialist equipment and specialist training, and it has been shown there is a potential for aerosol spread, and it is associated, as I said, with higher costs. And it must be carried out by a specialist and in a specialist setting like a clinic or in a theatre. So if we move over to mechanical debridement, the old method of mechanical debridement, which is not really used in this country and was used quite a lot in the United States, was wet to dry gauze. But it's basically not one that's used in this country because it was quite harsh. It could be painful on individuals who did not who did not suffer from neuropathy. And there are newer methods which are more selective and much faster and relatively pain-free. And I think Debbie might have a case of that because that is using the Deborah product for that. The disadvantage is wet to dry is non-selective and requires frequent dresses and changes, but the new regimes like Deborah Soft, that is not applicable to that. And the great advantage of using something like one of these monofilament pads, it can be used by generalists or specialists and can be done in any care setting. So then if we move on to sharp debridement, that's the removal of dead and devitalized tissue using a scalpel. Now that is a core competence of podiatry and tissue viability. And the advantages of this, it is selective, it's quick, and analgesia is not normally required, especially in the individuals with neuropathy. But clinicians need to be able to distinguish tissue types and understand the anatomy, as the procedure carries the risk of damage. And obviously, we must know what the underlying structures are and how to identify them, and make sure that we're not working beyond our capability. This can be done in the patient's bedside or in the clinic by a skilled practitioner. Then if we move on to surgical debridement, we know that is the excision and wider resection of non-viable tissue. The advantages is it is best used in large areas, and it is rapid. It has rapid results, obviously. The disadvantages, it can be painful for the patient, and anaesthetic is normally required, and obviously because of a surgeon's time and in theatre time, it's associated with higher costs. So it must be performed in a theatre by a surgeon, or maybe some specialist podiatrist or specialist nurse following training. So that is a quick resume of the types of debridement. But we have to know that before any decision on which methods that we are going to use or considering using, we have to do a thorough assessment of the ulcer that is facing us. But that is probably following the thorough assessment of the individual as well. We've got to decide what we hope to achieve by selecting the type of debridement that is suitable for that ulcer and for that individual. And we've got to decide how quickly we wish to achieve that. And we have to manage our patients' expectations as well and discuss this with our patients. We have to decide which method would best suit that individual. And I always think it is better to discuss that with the individual and explain what you are doing, and to inform them and involve them in their care. We also have to consider the environment of which this is going on and which it's going to be carried out in, whether that is in a patient's home, whether it's in a clinic, whether it's in a ward-based setting or whatever. But very importantly, we have to be aware of the competence level to practice safely and effectively, to make sure that we are working within our competency. So very quickly, I wanted to illustrate this by showing you this picture. Now, this is a chap who is painting a wall. To me, he looks as if he's doing a fine job. He's getting a good coverage. He's probably dressed appropriately. He's got the right tools, and he's doing a very good job with the tools and experience he's got. But I have another image of somebody else who is painting possibly the same wall, but he's doing it to a very, very different level. He's had more experience, he's had more training, both theoretical and practical. He has to use more extensive tools. It might take him slightly longer, but he gets very different results. Now, this chap may well have started off as a painter like the other person in the first slide, but has moved on and learnt and is now capable of doing this. The person in the first slide isn't capable at present of doing the one that we're looking at here, but the chap here could go back and do the other ones because he had that core skill. And I like to demonstrate this by the use of this rev counter, because if we're looking at this, if we look on the left-hand side, this is where a generalist would probably be. And if that rev counter was moving up through mechanical, larvae, ultrasonic, hydrosurgical, sharp, and surgical, then if you see that rev counter moving, then we're increasing possibly the speed of debridement, but we're also increasing the specialist training, etc., that is required to carry that out safely and effectively. And that brings me on to the capability framework for the integrated diabetic lower limb care. Now, this is not just for podiatrists. The original document was probably more podiatry focused, but this is a framework for anybody involved in lower limb care. If we look at our diabetes population and we look at the training involved in treating the different risks associated with somebody with diabetes, if we're looking at the low risk individuals, the competency framework levels are from A to C, which are the lower end, and then the moderate risk go to C to E, the high risk go up to D to E, and the ones we're talking about today with the active foot ulceration probably are up in about the E to F competency levels, and we'll expand a small amount on that. So if we look at this list of competency statements laid out in the capability framework, there are 16, which shows you all the different elements that are required when we are treating the lower limb in individuals with diabetes, and those are generic, screening and assessment, dermatology. I'll not go through all of them. You can see exactly what they all are. But in dimension 9 here in wound management is the one we're going to be quickly covering here. And the subset of that is debridement, which I wish to concentrate on. So if we look at the healthcare technician, debridement is probably not applicable for that level of healthcare technician to be carrying out. As for the healthcare assistant, they are probably not going to actually be carrying out debridement. But as we move further up to level C, which is a qualified clinician, if we look at the debridement element here, the capability that is expected is that that individual understands the principles of debridement and wound bed management to optimize the process of healing. They will be able to carry out wound management techniques within their scope of practice. They also an understanding of the requirement for onward referral to multidisciplinary input and a regional and an understanding of regional and guidelines and excuse me, regional and national guidelines and pathways. If we look at the specialist clinician, this individual carries out sharp debridement of simple and complex wounds within the scope of practice. They appropriately recognize the need for advanced debridement and refers the patient accordingly. They have an in-depth knowledge of debridement techniques other than sharp debridement. They clinically analyze wound care interventions to develop evidence-based individual care plans and carried out advanced wound management techniques with appropriate support and supervision. If we go to the advanced clinician, debridement, we have to carry out advanced debridement with a range of debridement tools of complex wounds, but yet again, importantly, within the scope of their practice. They have to carry out advanced wound management techniques, i.e. topical, negative pressure, etc., etc. And we recognizes the need to refer patients for surgical debridement when appropriate. And also have to support less experienced colleagues in developing advanced debridement skills. When we move up to the consultant clinician, these individuals lead in the evaluation of novel wound care products, provide clinical leadership, lead in the established working relationship with surgical staff, and provide expert opinion on debridement products, techniques, and indications in local and national expert groups. When we're looking at empowering clinicians to make safe, informed clinical decisions, I think it's like providing our clinicians with a toolkit. But that toolkit, we have to make sure is versatile. We have to make sure that that toolkit is available, and we have to make sure there is flexibility involved in utilizing that toolkit. I think the art of using a toolkit is knowing what tool to use and at that moment in time of when to use it and that really only comes with experience. We also have to know when using a different tool could well be more beneficial to the treatment outcomes or to the ulcer and the individual that we're treating. And when it comes to debridement, never be afraid to change the method of debridement if you feel it is not producing the outcomes that you hoped it would. Never be afraid to change that. And also be aware that at any time you may need to use more than one form of debridement during a single treatment session. So now I would like to pass you over to Debbie, and she is going to go through the rationale and clinical decision making involved for debridement, and I think is going to talk you through a real life case study. So I shall now pass you over to Debbie.
Hi there, Duncan. Thank you so much for your presentation, and hopefully it leads quite nicely on to my presentation here. So I would like to start off by providing a bit of background on the chronic wound, as well as going on to doing a clinical case study, as Duncan had said. So what is the point of all of this? Why are we having to have this presentation and considerations on wound debridement for these chronic wounds? Well, the reason is that non-healing chronic wounds remain a major area of unmet clinical need. And in 2020, Gestalt suggested that chronic wounds were costing the NHS over £8.3 billion a year. And in terms of clinical care and dressings, and of course impact on our patients, that is massive on our healthcare systems, particularly when we are constantly seeing in the press the demands on the NHS and how much it's in crisis anyway. So it's estimated overall that approximately, from Gestalt, that 2% of the adult population in the UK is actually affected by an active leg or foot ulceration, which equates to around about 1,054,000 patients. And this, unfortunately, continues to rise. Indeed, the slide that I had originally put on using my guest reference, the original one was Gestalt from 2015. So what the figures are presented is the more up-to-date 2020 figures. When you actually look back at the 2015 figures, then it was estimated that 5 billion of the UK population were affected by chronic wounds. Now, within 8 years or 7.5 years, that's actually went up to £8.3 billion. Okay, so this is an ever-rising problem, just in a short time in terms of reference, that impact not only in the amount of patients, so it's went up from 730,000 patients up to 1,054,000 just in that short period. So this is something, as time goes on, that's only, unfortunately, going to worsen it, unless we as healthcare professionals can do everything that we can to try and help our patients get to that ultimate goal, which is healing of these wounds. So this in turn leads to not only the impact on healthcare services, it also has an impact on a patient's morbidity and mortality, and of course their quality of life. So while they're living with these wounds, it can have a huge burden not only on the financial system, but on the patients themselves. These wounds can be devastating for our service users. So wound chronicity can arise through a malfunction at any stage of repair in wound healing, and can be influenced by a multitude of different factors. Some in isolation, but mostly you'll find that these are a complex interrelationship of multiple examples of these risk factors. And in fact, Schultz et al., as seen in this diagram here on the right-hand side of the image, proposed wound bed preparation and time model as a standardised critical thinking framework to help guide the clinician to consider holistic, multidisciplinary considerations to wound chronicity, which include patient-specific issues such as a person's social or psychological or environmental factors and influences, There are comorbidity factors such as chronic disease and the management of these diseases, and of course increasing age and malnutrition. Other factors we should be considering, such as the wound itself through the TIME acronym, and that is to consider what type of wound you are dealing with. Is it a pressure wound, a venous wound, an arterial or a diabetic wound? What type of tissue may be present on that wound? Are there positive or negative tissue types? And if there are negative tissue types, in terms of the debridement, what should we be doing in terms of debridement methods? Are there signs of any infection or chronic inflammation? Are the moisture levels for that wound too low or too high? Or just right, but yet there still isn't advancing of the wound? And you may notice that also that the edges to the wound may be getting bigger or smaller or deeper or shallower. So assessing all of these aspects is really vitally important in terms of how you are able to target your treatment priorities. And you will notice that looking at this figure, I have also added on another wing to this wound bed preparation in time. And this is the Debbie Wilson adapted version, and that's as a podiatrist where we deal with structural, functional and pressure areas involving the lower limb, particularly the foot. Challenges of these limbs can be directly as a result of pressure and trauma, and therefore when dealing with the chronic wound and lower limb chronic wounds, then you can't not consider this as a major impact in wound chronicity and therefore has to be a treatment priority. So in addition to the consideration of risk factors contributing to the chronic wound, like Schultz et al. Has asked us to do in terms of wound bed preparation and time, we must also as clinicians must be able to recognise the limb at risk for amputation and the requirement for urgent escalation of care. It's okay for us to just focus on, oh, you see some sloughy tissue, then you've got to debride it. But it's absolutely vitally important that you are sensibly assessing this limb in terms of risk to amputation and urgency of the level of care that that limb requires before you then start saying, oh, that's a nice bit of slough, I think I'll use a debridement method on it, when quite clearly there is very acute life-threatening infection that needs to be dealt with in addition to that. So systems used to classify the risk of amputation and the likelihood of benefit from revascularisation include older systems and well-known systems such as the Fontaine and the Rutherford systems, where they invite the clinician to subcategorise patients into two groups, and that is those with ischemic rest pain or those with ischemic rest pain and or tissue loss. But due to demographic shifts and the dramatic rise in incidence of diabetes mellitus, it has become increasingly difficult to perform meaningful outcomes analysis for these patients with threatened limbs using just these classification systems. And therefore, in 2014, the Society of Vascular Surgery published the Wi-Fi, that is wound, ischemia and foot infection classification system for staging lower extremity at-risk limbs for the risk to amputation. And subsequent meta-analysis of Wi-Fi publications confirmed it to be predictive of 1 year amputation risks. So for us as clinicians, the evidence is supporting that when assessing wounds and in terms of their risk to urgent amputation and of course urgency of care, that this is a system that in terms of the evidence is supportive of having a fairly accurate prediction of that amputation risk. So if you take a look at the Wi-Fi image on the right-hand side of the slide, you will see that the assessment of the wound size, depth, severity of ischemia and the severity of foot infection are graded from 0 to 3. And 0 being the least risk and 3 being the most severe. So for this particular case, for the image on the left-hand side, you will be able to see that this has a Wi-Fi staging of 3 for the wound. That is, it is an extensive ulcer Okay, with gangrene, you can see that the ulceration is not just affecting the digit, but it's into the forefoot and heading towards the midfoot and likely has deep abscess into the midfoot. There are zeros, so there is palpable pulses, and at this point, no ischemic risk. But however, when it comes to foot infection, this individual was presented with systemic symptoms. So if you were to then calculate the Wi-Fi risk using 303, this would bring a Wi-Fi stage of 4, which is a high risk to amputation, and the benefit of performing revascularization for this patient would be low or would have nil benefit. So the focus in this individual is for debridement and is for infection management. So how is it that I know this? Well, using the information for each category, the wound depth, the presence of infection, and vascularity of the limb from 0 to 3, I was able to calculate the patient's risk to amputation score and a recommendation for the benefit of performing revascularization by downloading the ESVS Guidelines app. And that is an app which is free and downloadable via Android and iOS in the available app stores. And this is a great app which has a Wi-Fi calculator in it, as well as international guidance on the treatment and management of ischemia and peripheral arterial disease, where you can work out the score easily and quickly. And if you can see here on the right-hand side of the image, here is an example of what the calculator looks like and where you would, as a clinician, would fill in the drop-down boxes and the Wi-Fi score and recommendations of urgency of care would be recommended to you via this app. So if you're an individual in the community being presented with this patient and really need this additional guidance, this is a really valuable tool for us. So in terms of wound chronicity, one of the most discussed causes of chronicity, as highlighted by Wi-Fi in terms of risk to limb, is the presence of infection. So where opportunistic critical colonization of a wound by microorganisms can lead to the formation of biofilm and of course to infection, which may in worst case scenarios be not only limb but life-threatening. So what is a biofilm? Well, the term biofilm was first used to describe surface adherent bacteria which is encased within and protected by a produced glycocalyx, and today more commonly referred to as an extracellular polymetric substance, or EPS. And today biofilm is implicated in numerous bacterial infections, including those associated with urinary tract, ear, sinuses, indwelling catheters, cystic fibrosis, periodontal disease, and of course, chronic wounds. And it is likely that at least half of all chronic wounds contain a biofilm, so that's half of all of these wounds. However, actually, there are more recent studies which suggest that biofilm involvement is actually has been found in up to 80% of chronic wounds. So if you are involved in chronic wounds and chronic wound care and management, the likelihood of your patients experiencing or suffering from the results of chronic wound behaviour from biofilms are going to be a likely contributor at some point in that wound journey. And additionally, it became evident that infections associated with bacterial biofilm persisted despite aggressive antimicrobial therapy. So not only were the presence of biofilms delaying healing, but when we were trying to treat these wounds in terms of application of topical antimicrobials, then they were resistant against the therapy. So if the majority of these non-healing wounds contain biofilm and it has a role in delayed healing, then biofilm could be contributing to many billions across the global cost of chronic wounds. Biofilm tolerance to antimicrobial agents and host defence mechanisms is now well documented, and this highlights the importance of effective biofilm management in chronic wound infections. And recent evidence from animal models has demonstrated that biofilm creates a low-grade and persistent inflammatory response, and therefore can impair epithelialization and, of course, the formulation of granulation tissue. So recognition that the majority of chronic wounds will have or at some point be affected by biofilms means that strategies to prevent, manage or remove these biofilms should be considered. And strategies to include biofilm and encourage progression to wound healing include debridement, appropriate antimicrobial therapies, and of course, dressing techniques. So let's consider the debridement methods. So as Duncan had alluded to, wound debridement is the removal of that contaminated tissue and cells, which is necessary for that optimal wound healing. But interestingly, and of course, what Duncan had alluded to was the different skills required for debridement, and of course, the different methods of debridement. There actually isn't any definitive evidence to suggest that one method of debridement over another is actually any better. And this largely rests on either the clinician's experiences or abilities. Other limitations to debridement methods as well could be availability and dressing formularies. For example, particularly if we're talking about mechanical debridement pads, are they available within your area to actually gain? And in terms of access to larvae therapy, is that actually a debridement method that is available to you within your area? So any decision on wound debridement should be part of that holistic patient assessment, considering the person-specific health and social circumstances, which is fundamental, and of course the skills of the clinician and what is available within that area. So Duncan had already alluded to the various range of debridement methods, including, of course, autolytic, mechanical, sharp, hydrosurgical, surgical, biological, and associated competence levels to enable that safe and effective debridement method being carried out. So, for example, with the autolytic debridement practices, via dressing choices, which are commonplace and used by all, and mechanical practices such as debridement pads, again, hopefully widely available, and again, in terms of skill level, can be used by pretty much anyone who's involved in doing dressings or wound care. And other than the practitioner skill, of course, it is the access to that. So let me present, for this evening, I'd like to present a clinical case and focus on this single case of wound healing journey, where a variety of different wound debridement methods were used for this individual. And that's what I'd like to emphasise, and Duncan had already alluded to. You know, when it comes to debridement methods, we don't pick one debridement method and we do it once and that's all that's required, you know, or we use one method and that's the only method that we'll use from start to finish through that patient journey. What you generally will find is that we use multiple varieties of different debridement methods depending on what's appropriate for that individual, for that wound type, and how the wound is presenting at that point in time. So thereby emphasising the requirement for that ongoing evaluation and that holistic patient-centred assessment during that single patient journey is absolutely vital. So methods used for this individual case were surgical, autolytic, sharp and mechanical debridement methods from start through to finish. So let me introduce you to Mr. A. Mr. A was 56 years old. His past medical history included type 2 diabetes, peripheral neuropathy, proliferative retinopathy and hypertension. And he presented to our acute diabetes multidisciplinary foot service with a foot wound which was Wi-Fi stage 4, and that was an ulcer that was deep to bone with the presence of digital gangrene. Now, it was his first digit, his great toe was gangrenous. He had an ABPI of 1.25, which was indicative that we had no concerns of his vascularity of the limb, but like the picture before, he had systemic inflammatory response indicators and his infection was spreading and becoming very concerning for his risk to developing sepsis. His particular patient-specific needs were that he was a single parent and he was a self-employed mechanical engineer, and this really was important to establish because it was felt that these were contributing factors that actually led him to present to us at such a late stage. This gentleman, when he was off work, it meant that he wasn't paid. So he had factors influencing his need to almost turn a blind eye because of his peripheral neuropathy. He wasn't in any pain, so this wound on his foot, he just kept thinking it'll get better, and could keep working. And in his mind, he's thinking, well, if I don't go to work, I don't earn money, and therefore, how am I going to look after my children? How am I going to give them the quality of the life that they require? So understanding his patient-specific needs and his particular story was very important in the long-term management. It wasn't going to be okay for us to say, well, if you don't do as we advise and say, then that's it. It was really important to demonstrate with him that we understood his circumstances and that we would do everything that we could to support him, hopefully as quickly through to the positive outcome of healing. And in terms of the action from when he presented, of course, at that point, it was admission to hospital for IV antibiotics and for medical and surgical assessment and management. And with that, he received digital and partial ray amputation. So he had that gangrenous limb amputated. So the first debridement episode that this gentleman has was on that admission, and that was for initial surgical amputation. So the debridement that he had was digital amputation and debridement into the foot. So he had amputation of the great toe and partial ray and debridement of necrotic and devitalised tissue in the theatre environment, and that was done by our surgical team. I'm sure there are areas in the UK where our podiatric surgical colleagues would be doing that, but in our health board area, it was our vascular surgical team. Now, he was thankfully then discharged with this wound here that you can see on the right-hand side of the image, and he was discharged by the surgical team into our podiatric care and management with shared care between the community, and that was community podiatry as well as community nursing, and of course our acute diabetes multidisciplinary diabetic foot service, so that we were continuing that holistic assessment of not only him, but of course for the management of his wounds. Now, it's important to understand that in diabetes, the diabetic environment, over half of foot ulcers and diabetes will develop an infection. And factors which may increase the risk of infection is diabetes-related immunosuppression, high rates of anterior nasal colonisation of Staphylococcus aureus, and of course, more frequent encounters with the healthcare system. Local factors can include the presence of peripheral arterial disease and venous and lymphatic insufficiency, obesity, and poor foot care practices of fungal infections. Therefore, one of the main priorities for this gentleman was, in addition to glycemic control, pressure relief, supported time off work, good wound care, and of course to promote that positive wound healing, was the recognition of an increased risk to that biofilm development and of course advancement onto further infection. So regular and appropriate debridement practices were vital to prevent biofilm formation and infection, to reduce the negative tissue types as they were appearing, to establish depth, determine structural involvement, to reduce callus buildup and reduce ulcer formation, and of course, ultimately, to promote healing. Other methods used for this gentleman were autolytic debridement, and autolytic debridement was promoted through the use of wound dressings and maintaining that moist healing environment, which was first observed in the 50s by Winter. And it's known that the body can self-debride by releasing these phagocytic cells and endogenous enzymes such as proteolytic enzymes and matrix metalloproteinases or MMPs. So by promoting that moist healing environment, we are promoting the body's ability to self-debride. And that's what we were trying to promote through our choice of regular review of wound dressings. In addition to that, as podiatrists, we were using regular podiatric sharp debridement. So this was in clinic debridement during wound dressings using a scalpel, and this was where calloused, fibrous or sloughy tissue was reduced or removed. So when you're thinking of the appropriateness of debridement methods, and we were considering larvae, so larvae is used frequently in wounds, but the problem is with larvae, where there is fibrous or scar tissue developing in a wound surface, then larvae will not remove that. So it's important to determine if there is the presence of a fibrous or scar tissue within that wound, then it wouldn't be appropriate in that instance to use larvae therapy. And you would be looking for a much more mechanical means of debridement, such as the scalpel and podiatric sharp debridement. Other terms of mechanical debridement include, of course, the mechanical role using a monofilament debriding device or a debriding pad, and one of them is known as Debrisoft, and that's the one that was used in this particular case. So for this, we consider its clinical applications, and particularly focusing on its usefulness in the removal and management of biofilms on that wound surface, and therefore its usefulness as an effective method to tackling the chronic wound. So in terms of evidence for using the Debrisoft debridement pad, well, they include NICE, the Medical Technologies Guidance MTG17, and this is titled the Debrisoft Monofilament Debridement Pad for use in acute or chronic wounds. And this report concluded that the available evidence was limited, but the likely benefits of using Debrisoft pad on appropriate wounds are that when compared with other debridement methods, and that in one of the papers it was against larvae, was that wounds will be fully debrided more quickly with fewer nurse or podiatrist or whichever healthcare professional is doing that dressing at that point were needed. And in addition, the Debrisoft pad was a convenient and easy to use and well tolerated by patients, because this pad is gently rubbed over the surface of the wound, and it wasn't, it's not like you're cutting or you're using any major trauma. Like Duncan had mentioned previously, the soaked gauze, where saline soaked gauze is left to dry in a wound and it is effectively ripped off the surface of the wound. That was the method that was being alluded to in that instance. That is not required for the Debrisoft pad. It's just a gentle moistening of the pad and then circular rubbing the area over that is requiring the debridement. So debridement is obviously an important component of standard wound care, and this was recognised in this report. And it was recognised also in the NICE guidance on pressure ulcers, now as CG179, and in diabetic foot problems, which is the NICE guidance NG19. Other evidence from Wilkinson et al. In 2016 in a study to combine controlled and defined debridement application with a biologically relevant ex vivo biofilm model to directly compare monofilament debriding devices. So basically this study took porcine skin samples, and the porcine skin samples had colonies, biofilm colonies of Pseudomonas and Staphylococcus aureus grown on them. Different debridement methods were then used to try and disturb and remove the biofilm. Okay? And what this study found was that the data supported the use of the monofilament debridement devices, i.e. Debrisoft, for the removal of established wound biofilms, and suggested variable efficacy towards biofilms composed of different species. So they found that one species was easier to clear than the other. But interestingly, histological and morphological analysis suggested that debridement not only removed bacteria, but it also differentially disrupted the bacterially derived extracellular polymetric substance, the EPS, And finally, the SEM of post-debridement monofilament showed structural changes in the attached bacteria, implying a negative impact on the bacteria's viability. So it was able to show that there was disruption of these biofilms using this method of debridement. So what is DebriSoft, this mechanical method which I'm describing well? Here is an example in the slide that was used with this particular wound. So it comes in various sizes and application methods, and one that's of particular use, particularly for those deeper or irregular wounds where there is undermining edges within the wounds that are kind of hard to reach or lip underneath, and is a particular area for biofilm and bacterial growth, which can go really unnoticed within a wound. That this debridement lollipop was particularly useful and could not only go over irregular surfaces, but could get under the undermining edges of these particular wound types. And as it was a soft pad, patients rarely found that of any discomfort or any complaint, really. And another pad that was used, particularly when the wound was becoming more shallow and advancing to healing, was the debridement pad itself, which came in a 10 by 10 square and was easily softened wet with water and then easily rubbed on the surface, so you were physically picking up the apoptotic cells and bacterial debris. But in addition to that, if you were to use it on larger wounds, you can get pads from 13 centimetres to 20 centimetre pads as well for much larger wounds. But for foot wounds, the 10 by 10 was really very effective. So here we have an example of where I was able to demonstrate the pre and post image, specifically using this 10 by 10 DebriSoft debridement pad. So in podiatry, we use our scalpels a lot for not only debriding slough, cellular debris, scary tissue and callus, but here I think is a lovely example as well, where we can see that this debridement pad not only can take away the apoptotic cells, the cellular debris, but also callus areas round the edge and eschar round of the edge of the wound, and in terms of wound bed preparation and preparing that wound for positive wound healing, we are getting a lovely clean wound bed, but as well as using the pad as a physical debridement, we are agitating that wound. And by agitating that wound and disturbing that wound, what we are doing is almost wakening that wound up and trying to encourage that acute wound behaviour. What we find in chronic conditions, or patients that have chronic conditions with chronic wounds, is that these wounds generally tend to go into that chronic phase and stop. It's almost as if the body has disconnected from its immune system, like it doesn't recognise the wound is there. And when you've got all these risk factors, you think you've nailed everything, in terms of pressure relief, glycemic control, vascularity, but the wound still doesn't heal. Sometimes what we find in debridement is by using a mechanical force, but not being too traumatic to the wound, it almost helps to reinvigorate and waken that wound up again. So the key points really are that debridement to remove biofilm formation, necrotic and or affected tissue, and can promote active healing remains a cornerstone of contemporary chronic wound management. A variety of different debridement techniques are available, and as Duncan had alluded to, require a varied skill set for accessibility. Holistic, multidisciplinary, patient-centred assessment is vital to ensure the appropriate and safe patient care and management for all. And a variety of debridement techniques can be required for an individual's journey, and that we don't just pick one debridement option and follow it through. And we also don't just do one debridement episode and that's it until the wound is healed. And DebriSoft is a convenient and easy to use method of mechanical debridement supported by limited but convincing evidence. And the Medical Technologies Advisory Committee made a positive recommendation for the adoption of DebriSoft and has been published as NICE Medical Technology Guidance MTG 17. So thank you very much, ladies and gentlemen, for listening to that presentation. And now it's time for me to hand you back over to Alec.
Thank you, Debbie. Excuse me, and thank you, Duncan. Really interesting. I've been writing loads and loads of notes. I'm going to keep my comments fairly brief because we've had so many questions coming through. But one of the things that's very obvious is that a lot of people are across the country in very different situations when it comes to debridement with regards to the guidelines that they specifically have in the areas that they work and the products they're able to access and stuff like that. So that's a really interesting thing that perhaps we can pick up on another time. I'm going to get straight to the questions because as I said to you at the beginning, if I don't, we will end up spending most of the time just talking about my questions. And we've got quite a few here. So the first one is from Carolyn Jane. And this is, what recommendations could you give for best practice in wound debridement in the community, please? Duncan, Debbie, either of you want to take that? So that's, what recommendations could you give for best practice in wound debridement in the community, please?
Well, I'll maybe kick that off and then Debbie will probably want to come in. Best practice, it basically depends on that individual's capability. And so we have to make sure that we are providing the debridement method that is suitable to that individual that we're treating and to that wound. And if we're not able to do that, then that should entail onward referral. So the best local guidance is basically governed by the capability of the individual that is treating that patient. So there is no succinct guidance that you must use this at this stage or this at this stage. It is to do with assessment and what is available to that individual and their skill of using those tools. Do you know of any local guidance that people follow, Debbie, or is it just down to what I've been talking about?
Well, no, I would agree with what you've just said, Duncan. I've basically discussed that the evidence doesn't support one method over the other. It really depends on that particular patient's presentation, So in one instance, you could have sharp debridement by a podiatrist because they require the physical removal of a plug of slough, which could easily come away with a scalpel, or you could have somebody that has a necrotic area which could be debrided as a result of infection. But in another patient, they may have infection with the same type of necrotic plug that needs removed, but they have a critically ischemic limb. And therefore, that method of debridement would be completely inappropriate for them. But in the other person, it's the perfect method. So it really is down to that individual presentation, circumstance, and skills within that area. But certainly what I was trying to allude to in terms of minimal but regular and widely available debridement practices, the mechanical debridement pads are very, very effective in trying, to have access for all healthcare clinicians in terms of trying to control the buildup of negative tissue types or where there is suspicion of biofilm involvement, which may then lead on to worsening infection, worsening presence of negative tissue types.
Yeah. And you can see that, I guess, thank you both, by the way. I guess you can see as well that over the last sort of maybe, I don't know, 10 years or something like that, with the invention of various products, Deborah's not being the one that we were talking about this evening, that the idea of debridement has clearly become, and, wound bed preparation, because that's another term that we use. So wound bed preparation, debridement has clearly become something that is very obviously very, very important. Yeah. So I think you mentioned quite a lot in your presentation around the different methods. So we'll skip on to the next one. We have Antonia, I think I'm going to say this right, possibly Cichi, C-I-C-H-Y. I'm going to say Cichi. Antonia says, agreed, we do need a thorough assessment of the wound. We often have, it says, if we often have time constraints, what would your advice be in that instance? Either one of you want to take that?
I'll quickly start off again and say, if time you shouldn't be progressing with any form of debridement if you have not managed to carry out a proper assessment. So if for some reason you cannot carry out a holistic assessment, I would say less would be more, and I would not be gung-ho and just charge on into any wound unless you have properly assessed it. So try and make time, because you do not want to charge into a wound unless you could do more harm than good if you have not properly assessed that individual. So if you don't have time for assessment, I would say do the minimum amount of debridement. Debbie, what do you think of that?
No, I would agree with that. Yeah, I would think wherever possible, if you're considering debridement methods, then absolutely you must do a thorough assessment. And where you really are pushed for time, we've all been in these situations, where your waiting room is full, or you've got doing house visits or what have you. We've all been there. Then that is not the time to be implementing debridement methods that haven't been thoroughly thought out.
Especially if there's a vascular element, you might need to hold off with any sort of radical debridement till there has been some vascular intervention and hopefully an improvement to the circulation. And then once that has happened, then you can carry out more extensive debridements. But we have to be even more careful and take things a lot easier on those vascular individuals.
Okay, we're slightly over time, but we've still got plenty of people watching. So if it's okay with you, Duncan and Debbie, I've just there's certainly one question that I'm looking at that I think is just a really interesting question. And that's before we even get on to all the acronyms that I've written down tonight, Wi-Fi and ESVS and all the rest of the things, which are obviously really interesting. And I'll talk to you about those offline, but we'll make this the final question. Before you answer this, I'll just say what I say every time, which is that we do keep a list of every single question that has come in. And what we do is we take those questions, we share them with Duncan and Debbie and the team at LNR and my editorial team. We create a Q&A, and then when an edited version of this goes on to our website for you to watch at a later date, the Q&A will be next to it with all of the answers. So I do apologize profusely if we didn't get to directly answer your questions tonight, but we will get to answer it at some point. So for the final question, before I just have a few more points to say, is how do patients find having their wounds debrided, and how do you know when to stop debridement as part of the treatment plan? Let's start with you, Debbie. What do you think of that?
I tend to find that patients are very open to having their wounds debrided, and hopefully the reason why that is the case is because it's something that I have discussed with them before I implement any debridement process. So I'll always go through the wound assessment with the patient, and if I'm thinking of any debridement method, then I will discuss the various different debridement methods that are available. I'll try to consider the risks and benefits for both, and which of them I think would probably be more pertinent to the wound. So generally, by the time I get to the point of actually doing debridement, it is a decision that actually both of us have been involved in, that there is understanding of the reason for that debridement process. And therefore, as a result of that, they tend to be very keen, because these are patients that have chronic, slow healing wounds, and they really are wanting any method used in terms of trying to promote wound healing as quickly as possible for them. So as such, you generally find that they're very open to the debridement methods. The particular patient population that I have, which is a diabetes patient population, means that the presence of peripheral neuropathy is very high. So therefore, in terms of pain and discomfort, the majority of our patients tend not to have any pain sensation. And as such, I can probably do more extensive sharp debridement techniques in my clinical environment than somebody who, say, doesn't have peripheral neuropathy. So it's not to say that I don't have patients that feel pain, but the majority of my patients don't really experience much pain. So I can even go as far as to do digital amputations in our clinic where there is gangrenous loose toes. I can remove those toes in the clinical environment without having to consider anaesthetics or anything like that. Even the Versajet procedure, in terms of that, if it's somebody
Debbie, I'm gonna cut you off. I don't think I heard this. I'm gonna give Duncan 30 seconds, if you don't mind, just to check something on, because we're running quite a bit over. So if that's all right, Duncan, can you
absolutely, yeah, that's
30 seconds worth?
Yeah, that's fantastic. I think Debbie's covered most in the fact that you do discuss with the patient, you discuss the different options, you discuss the different outcomes of that, and because you have to manage that patient's expectations of that. But I think involving and informing the individual that you're treating and taking them through the journey and explaining to them if you change the method at any point, I think you get buy-in from that individual, and that tends to give you better patient relations and better outcomes.
Thank you very much. Listen, I feel like as though the last question is an entire hour's discussion in itself. So there's probably loads of things that we can perhaps talk about in the future. But listen, I just want to thank you both. Duncan, Debbie, thank you very much for the presentations tonight. We couldn't have done this without the sponsors, LNR. So I'd like to thank the entire team at LNR. You talked a little bit about Deborah. I personally have a bit of a soft spot for that product because we've worked with it for a long time. And, you know, when you bring a product to market, one of the biggest compliments you can get is when other companies bring something out similar. So I think that's great news for LNR. I'd like to thank my team behind the scenes who nobody sees. Nobody ever sees all the people that are involved in these events, but there are people who are pressing buttons right now showing links on how to get your certificate. So keep an eye out for that. If you are not joining us at Wound Care today on the 1st and 2nd of March, that's next Wednesday and Thursday in Milton Keynes, my big question is, why not? Get yourself onto our website and register and take a day off or do whatever you need to do to come and join us. We're really excited to join LNR and the rest of industry there. So please do come and join us. Keep an eye out for myself. We've got some various competitions running. You can see more about Deborah Soft, more about LNR at one of their skill zones at the event. Finally, I think Duncan, Debbie, thank you very much again. And good night, everybody. Go have a glass of wine, watch some football, watch some TV, do whatever you're doing, and we will watch you again, or we will see you again at the next Facebook Live in a couple of weeks' time. Thank you very much, and good night.
Thanks very much.
Good night.